It's my honor to present our next speaker. Dr. Michael Curci is a friend and fellow pediatric surgeon who's going to speak to us about the development of pediatric surgery in Rwanda as a model for global health. Former retired pediatric surgeon from Maine Medical. Thank you for joining us.
Thank you for inviting me today. Before I start the formal part of my discussion, I'd like to congratulate Dr. Scott. I think emphasizing a needs assessment is critical if you're going to get involved in global health. And hopefully my talk will give you an example of how this is utilized and I think has been successful. My discussion today about the model that was used in Rwanda is biased by my experience in Haiti and East Africa over a 50-year period. How do I advance this? Is it working? Oh, there it is. I'd like to give you a little bit of my background, which will give you some perspective of where I'm coming from. I was fortunate to start getting involved in global health as a medical student. I spent 2 months at the Firestone Plantation in Liberia. I then went on to a general surgical residency and spent 5 months out of my 5 years at the Albert Schweitzer Hospital in Haiti, which would not be allowed by the ACGME in today's criteria. I continued my association with Haiti during the next almost 50 years, first with my family and then with our residents, faculty, and nursing staff at the Maine Medical Center. I retired in 2008 as the General Surgery Program Director and began, with the extra free time I had, to develop my further interest in global surgery. I initially spent 3 years in Tanzania. This was an educational model with service dealing with non-physician clinicians. A brief period in Malawi, but the most exciting and rewarding period, I think, of my retirement years and probably my professional career has been working in Rwanda during the past decade. This is a generalization. I think some of the models that we've utilized in the past has been the old model, which is a short-term visit, well-intentioned, services provided, but education was limited. The newer model has a needs assessment, which is very important, in conjunction with the Ministry of Health and the support of the high-income countries. Block grants, which are now being used more frequently with limited NGO presence. It establishes a sustainable goal, which is different for each country, which I think is the important concept here. I use this slide frequently to show the immensity of Africa and the number of nations that you can put within its geographical boundaries. With the limited number of physicians that are being trained, who usually migrate to the urban areas, the rural population, which is the greatest portion of the population, has its medical cares provided by nurse practitioners, traditional healers, and non-physician clinicians. This is the program I became involved with a decade ago. It's Rwanda's Human Resources for Health program. It was a 7-year program which has been extended. It involved many U.S. centers and university partnerships. There was a $170 million budget. And the primary focus was to populate the district hospitals, which had been decimated by the genocide in the 1990s. In addition to that, it also had a program where you assisted the brighter Rwandan surgeons to provide faculty capability to sustain the training program, which did not exist when we arrived. As far as pediatric surgery, the population of 12 million people had no pediatric surgery service capability, and 50% of the population was less than 15 years old, again due to the genocide. One of the unique concepts in the program was the twinning concept. This involved working with a Rwandan surgeon to develop their capability in terms of education and potentially interest them in the field of your endeavor. I met Dr. Edmund. He was a bright, motivated, young general surgeon who, after spending 3 months with him, agreed that pediatric surgery was the best fellowship to have. So he went off to Kajabi, which had a CSUS fellowship. It was a 3-year program, and he returned in 2017. This was followed by Alon's Jules, who again felt that pediatric surgery was his calling. He went on to Kajabi, also took a 3-year fellowship, and returned in 2020. We now had a program where we had the beginnings of a service which we wanted to encourage sustainability. We took one of our adult anesthesiologists and gave this person further training in pediatric anesthesia to provide safe anesthesia for the more complicated cases that they were now dealing with. The NGO Kids OR provided a pediatric OR for us in 2018. I'd like to give you just a sense of what a pediatric surgeon's life is like in Rwanda. This is the tertiary care facility in the capital, in Kigali. Here we have part of your referral system. This is a traditional healer, 2-month-old with pyloric stenosis. You can see the dilated gastric bubble in the mid-epigastrum, but you see these scarified lesions, which are supposedly diagnostic and also treatable for this disease. Obviously, it didn't work. Some of the common things we see are common in our high-income countries. This is a left upper pole Wilms tumor, which we obviously see a late presentation. This is a 3-month-old with Hirschsprung's disease with a transition zone in the sigmoid colon. And then there's the other diagnosis, which you don't see in our setting. Right lower quadrant pain or lower abdominal discomfort is not appendicitis. It may be a typhoid perforation, which you see here in the distal ileum. Or it could be ascaris with pressure necrosis of the distal ileum. Then there's the unexpected, something that you may not have seen in your practice, as I had not seen. This is a cleft sternum. What you see is the scarified pericardium, which separates the heart from the outside world. This was repaired. You see her at 2 years of age. And during this past year, I visited the family in Rwanda again, and here she is at 6 years of age with no cardiac limitations. But then we see things that we can't treat probably anywhere, whether it's here or in a high-income country. But here is one of our success stories. This is a gastroschisis. The incidence is quite high in Rwanda. We see at least a couple of these a week. At any one given time, we have 6 or 8 of these cases in our neonatal unit. Initially, when I arrived, the traditional care profile for this lesion with a probably greater than 90% success rate was unavailable, and we didn't think you could possibly treat these without a ventilator or central hyperalimentation. We realized that we had to think out of the box. We now treat these patients with a reusable silo. We decompress the abdomen, cover it with the umbilicus, and let it granulate over. The survival rate has gone from 0 a decade ago to now 30 or 40%, which is good, but obviously there's more to be done, but we're not ready to treat that. We don't have that capability yet. The exchange program that we try to encourage is important. You see here the third-year Rwandan general surgical residents who will rotate through our service. We have a third-year resident from our institution in Portland, Maine, and also a young pediatric surgeon from the same institution. I'm frequently asked, how do you become involved in global health? These are some of my own personal observations. There are other choices that are available. But I think you need a local champion and a visiting person to work in a low and middle income country. You need to establish an ongoing presence before any exchange programs can occur. I spent 3 months every year for 10 years getting involved and encouraging the development of a pediatric surgery service. You have to have clear expectations. This experience, is more than just doing complex cases. It involves education, support for development of the residency and nursing training programs. The challenge is maybe complicated. My experience is a little bit different since I did it in my retirement and I had all this extra time. The challenge is a limited time available in practice for frequent presence and to establish a relationship. The problem is that a single institution may not be able to provide this commitment. Possible solutions are needed for individuals from multiple institutions or surgical societies to coordinate the health care in a low and middle income country. At the present time, pediatric surgery in Rwanda is self-sustaining. I have made myself obsolete. They don't need me anymore, and I'm now an ambassador. I thank you for the time and allowing me to present.
I enjoyed your talk very much, having went to Bolivia for 15 years, and I liked one of your penultimate slides that just kind of drives home the fact you have to have some stability in terms of the government where you're going. You went to Rwanda. How about little things like the Rwandan genocide, and who's in charge when you set this up? Because, you know, granted, just going, dropping down, doing cases and going home, that makes you feel good, but in the long run, it doesn't benefit. So in your experience, how did you come to some level of comfort that when you were going there, that there was somebody on the other end that was committed to make this work, so you weren't just going and the subject to somebody's agenda, that you went over there with the best of intentions, but you were a part of an agenda rather than really a part of a program that somebody on the other end wanted to make sure worked?
Well, I think this is originally a Clinton initiative, probably based on genocide guilt, but this was a program that was set up by USAID and several other global institutions. There was a program outlined for probably, early on in the program, probably 80 to 100 physicians were involved with this. Rwanda is a modified police state. When things are organized, they're done with no further discussion. But I think it was done, I think the president has the best interests of the population at heart. And so he's in some ways a benevolent, I shouldn't use the word dictator, but he has enforced the appropriate needs of its people. I think the global funding is very important in terms of establishing the need assessment. This is done by the Ministry of Health and the University of Rwanda. Even the small stipend that you get while you're there goes first to Rwanda, then is sent back to the parent institution that you are involved with. So they very much speak for themselves, and in that way have a place in developing their needs. I feel in terms of safety, it's probably safer in Rwanda than it is visiting my family in New York City. So I was very comfortable, if that's an answer to your question.
Thank you.
Dr. Curci, thank you very much. Clearly a vast experience in global surgery.